Hi, Volker?
Yes, I hear you.
Very good. So first of all, thank you really very much for giving me the chance to present a little earlier, or more or less at the same time, because I got an appointment. I have to go back to the hospital later on. So therefore, thanks. I'm the unusual guy here in the setting. You're right. I'm doing some SI fusions, but I'm kind of I see there's a lot of experience here, which have done a lot of studies and things. So I was asked to talk about fusing the spine as SI joint same time, and I will come a little more on the philosophical than on the technical side, because you have shown very nice pictures how very sufficiently a doctor is able to fuse the SI joint. But there's a question of distal junctional pathology, and we know that we have a big problem, especially in the elderly, with junctional kyphosis and adjacent segment disease. But is it always above? Maybe no. Maybe it's sometimes below, and then this is why I come. If we talk about major deformity, which I do, adult deformity quite a bit, if it goes above 4 levels of fusion, if you talk about that, really, the base and where to put it is a question. And I already asked Jörg earlier on what might be a problem there, and he he said, well, yeah, if the balance is correct, everything works fine. That's true, and I agree. But especially in the elderly, it's sometimes really difficult to see it. So to really have the best of all ideas, if it's good enough or not. Thirdly, right, that's part of the truth as well. Anything which goes to the pelvis is challenging as a spine surgeon. So challenging anatomy, biomechanics are sometimes totally different than the normal ones of the lumbar spine. And the morbidity is something you shouldn't underestimate. It's related to some invasive procedures, and therefore this really gives sometimes kind of some questions which are difficult to answer. Why do we do that? If we talk about adult spinal deformity, and I try at the same time to give you, here we are. Hi, so I'm now, I just saw that I wasn't on video. When we extend our fusion to the spinal pelvic region for spinal deformity surgery, reasons are here on the right. High demands of fixation, pure bone quality, it's a major issue. It's not so much for the SI joint itself, but if we want to have a good base for our deformity correction, that's a problem. Neuromuscular deformities, Parkinson's is a disaster sometimes when you do those surgeries. Degenerative scoli is okay, but especially if you have high-grade spondylolisthesis, that's a problem with the base in the lumbosacral, in the spinopelvic region. And all those, there's really questions, and we need better solutions. And the controversies are still, if we do those surgeries, should we stop at the sacrum? Should we go to the SI joint, go to the ilium? And really, this is in the currently based on some evidence, I would say, and some philosophy. And what we want to achieve is clear. We want to have an increase our stability, resist the pull out, and maintain the balance. And but it's not solved yet, that's for sure. And the next question comes around then: are the outcomes outweigh the risk? If you put additional screws to different regions, you have to answer that. But what if it not fuses? That's another question. What if we try to fuse and you have a loosening screw, loosened screws, we have pullouts, we may have pseudos, and those things, it's really a problem. If we go back to history, our very experienced guys, I would say, like Daniel or Jean Debussy or Jackson, they showed us different techniques going to the pelvis, not only to the SI joint, Galveston iliac screws, we have the sacral block, we have direct intrasacral fixation for different deformities. So there are a lot of things around which enable us to fix something to that region in addition to a clear fusion to the SI joint. Those are more or less the things we do now. It's iliac bolts, transiliac bars at times, especially for more traumatic kind of things and osteoporotic related fractures. And we have the S2 a la iliac screws, which is not a fusion. You know, if you just put a screw through, then it's not a fusion. We should keep that in mind. But mainly we are talking, if we talk about deformity surgery and fusing the lumbar spine and doing some correction, we are talking iliac screws versus SI a la iliac screws. And then the difference is pretty simple. They immobilize the joint, but they don't cross with the iliac as they cross with the S2 a la screws. And they both are, you know, kind of rated probably pretty much the same. We, in my department, we do both. You know, at times we do this or that. That depends a little bit on the anatomy and sometimes on the surgeries before. But because a lot of those people, you know, have been operated before. This is I probably don't have to explain that to this audience because you all know S2 a la iliac screws, which go, you know, which start at S2 and then are going through the joint and entering the ilium in order to get a little more cortical bone, and they have a better strength than other screws, and that's been shown with pull-out strengths that for getting the base of your deformity surgery, those screws have a better pull-out strength than the conventional iliac screws. They are a little more demanding, you know, kind of getting the right trajectory for those screws. Therefore, you know, there's a better place for any navigation which we use in order to get a good hold on those cortical bony structures, which give you obviously more pull-out strengths. The other thing is, you know, there are a few points from some publication which are out there. You know, there is a SI joint pain after those surgery if you don't fuse the joint properly. There's not much difference in that study between the two screws. You know, the provocative tests have been used here to provoke the pain. There's one study I did, you know, with Kai Schäufler, which is a senior author here, which some patients which were operated, you know, using instrumentation, but there was a prevalence of 30% of remaining pain for the sacroiliac joint. And after a subsequent fusion of the joint, you know, that resolved in 8 out of 9 of those patients. And there was, you know, that was asked earlier, there was a high correlation between increased pain in the sacroiliac joint with high pelvic parameters, meaning high incidence means a rather more given chance to get in sacroiliac joint pain afterwards. So it is, if you don't fuse it, if you just put your screws, there seems to be a higher risk of getting a subsequent pain. And what is the signs of pain? You know, that's one, the halo formation around the iliac screws, that there's still motion in the SI joint. And this is usually related, but not in all patients. Some have those pictures and are totally fine. That happens as well. But, you know, a good percentage of those, you know, show some type of pain. And this is a sign that there's obviously the joint still moving. There are more complex problems. This is a guy which I operated, happened to be this week, and that, you know, they tried to fuse to the ilium, they tried to get a good base, but what you see here, there are big halos around that. There's an infection in the front, and what, you know, there's always the question, what do you do then? And as you can see here, right, there's big halos around the S1 and the ilium screws, and, you know, therefore, you see it here again. Solution was, you know, we found another way, and you see that big halos around the iliac screws, and with the navigation, we found another way of putting the S2 a la iliac screws and fused really the SI joint directly with even BMP, with inductor os. And what you can see from the post-op EOS pictures, you know, with an additional with an additional TLIF in L1-2, we could realign that and get the sacral balance back. And so therefore we hope now that, we could solve the problem. But really, it's not only primarily, but especially in revisions, this is always a question. It's not only the screw, how to fuse that. Because, that's our goal with adult spinal deformity surgery, decompression and the fusion and the balance and maybe some functional restoration. And we take a lot of function off with the fusion. So we have to keep them at least stable because it's really about balance. So first of all, you have to make sure that the balance is given, and then any fusion or anything for the SI joint gets more time to occur. That's really and less risk of loosening and breakage and all those things. Is there a place? Obviously, we heard the whole day. Yes, of course, and there is that problem if you go down to the sacroiliac area. That there is a remaining pain, so you should really look at this and consider doing a proper fusion there. Those are some projects, especially running, looking at the incidence, the revision surgery needed, and on the complex surgery database. That's very important because, this is the usual patient we get. Rather not skinny, quite a deformity, off balance in both planes, more on the sagittal usually. And then we see that and measure that, and we have to do something in the lumbar spine, no question. And in the old question is how deep you should go. In this case, I would have a Chopin block plate. I blocked that. That's a rather elderly case. Maybe nowadays I would rather put more attention on fusing the SI joint because I stabilized it, but I would rather put some more bone into it nowadays than I did years ago. That's another, that's some of the usual stories. Beginning in 2005, that's what I did. She was pretty okay, rheumatoid patient. And then, kind of 2007, we had to extend her. Then S151 went wrong. We had to do that. In 2014, some of my colleagues did the left SI joint, and then I she came back to me and I fused then the right SI joint after an injection. There's still, and what you can see, that's interesting, there's still that adjacent segment disease at L1-2, but this is not bothersome for her. We injected that, she's fine, and with the fusions, which I did in 2018, now she's still okay. Let's say pain okay. Pain-free is something, rheumatoid with already 5 operations will never have. So this is something we should really look at, right? This is SI bone solution, which I think is pretty interesting, with the bedrock, in addition to the base and the good screw base, iliac S2 ala ilium screws, or then really have a fusion device with it may solve some of our problems, and I'm very happy that the study is going on, and maybe we can be a part of it. So at the end of my talk, that's the usual finding for this decision, which I'm talking about. You have that sagittal and coronal deformity. There's obviously some compression or some stenosis with it. Patient can't walk, can't really stand for a long time. So the question is where to end. In this case, I was, which I did 3 years ago. I rather tried to avoid, the pelvis. I did no SI fusion. There was a good S2, so I put some good 2 S2 screws. In addition, there was no relief on prior SI joint injection. We work them up, those patients. We try to do conservative for a few years usually, and then if the point has come, we fuse them. So therefore, in her, the SI injection were usually not very, very okay, or not very kind of pain relieving for her. So we decided in that case to go to S2. But there are some questions to be answered, kind of from those, and you already saw both cases. benefit versus risk of SI joint fusion in long constructs. Really, this is something we have to see, because the real fusion of the SI joint with posterior procedures at the same time, or in the same time as the lumbar correction surgery is not that often done, I think. We should look at potential effects, which I asked Jean-Charles earlier, of the upper instrumentation end, because you increase the lever arm. If you take the SI joint off the motion, you increase the lever arm. And you have to look at the more distal joint and for the hip. If there's anything, if someone has hip prosthesis, we know for Bechrefs that you might get dislocation of prior hips. So really, this is something we have to look at in addition. And we have to look at the quality of fusion, how to prove that. Is it only no motion? How to prove no motion in the SI joint? You can only do it indirectly. Or do we rely on a real CT scan with bony bridges from the ilium to the sacrum? This is another question I would like to raise in this, especially in this audience with a lot of experience on the SI joint. Thank you very much, especially for the opportunity to talk a little earlier. Thank you.
So thank you, Jörg, for your talk. Very nice. I have one question. What experience do you have from this bedrock procedure? Because in my opinion, it's quite, or let's say it's not very easy to put in an S2 ala screw and to put in this bigger implant, even in almost the same position. I think this is quite demanding, isn't it?
Yeah, thing is, kind of, I showed this, I will hope I can be part of the study. Study is just run, so you come